A very good evening to everyone and a very warm welcome to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, he needs no introduction at our platform, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned anesthesiologist, Dr. Nishant Kumar, sir. Sir is MBBS, DA, DNB, MNA, AMS, professor at the Department of Anesthesiology at Lady Harding Medical College and associated hospitals. With such wonderful insights, we are going to talk about the topic for today as we are celebrating World Anesthesia Day. And the topic for today is management of intraoperative anaphylaxis, a case based approach in anesthesia. Before moving on to today's session, let us have a brief look on what the topic says. So, in a recognition of World Anesthesia Day, this webinar will delve into the one of the most critical challenges faced in the operating room, intraoperative anaphylaxis through real-life case studies. Expert anesthesiologists will share strategies for identifying, managing, and preventing life-threatening allergic reactions during surgery. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you. Please proceed.
Okay. A very good evening and a very happy World Anesthesia Day. So anaphylaxis is something that we dread and it can occur anytime. So I'll just discuss a case-based approach, how to identify anaphylaxis, what are the causes of anaphylaxis, how to treat it, what are the pathophysiological mechanisms, and what are the sequelae and how we can recognize it and treat it as early as possible. Next, please. So let us take this case, a 35-year-old female, ASA1, posted for laparoscopic cholecystectomy, which is being performed day in and day out, and nowadays considered not a very grave risk surgery. So normally we pre-medicate with midazolam 1 milligram, receive fentanyl 100 microgram, and an antibiotic. The test dose which was seen and the test reaction was negative to that particular antibiotic, which was administered in the ward. So, without further ado, after the monitors were attached, the anesthesia was induced with propofol 100 milligram with sevoflurane, oxygen and sevoflurane, oxygen air and sevoflurane, and for relaxant insertion of a tube, facilitation of the surgery, rocuronium 30 milligram at the rate of 0.6 milligram per kg was administered. Suddenly, after 2 minutes of ventilation, the patient presented with hypotension. There was a drastic decrease in blood pressure. The blood pressure dropped to 60 systolic. There was marked tachycardia. The heart rate increased to 120. The tube is, remember, not in as yet. There was a fall in SpO2. The saturation had dropped to around 70%. There were on auscultation because there was shark fin appearance on the EtCO2 and there was bronchospasm on auscultation. So bronchospasm was suspected, and now it is up to you to recognize what actually has had happened. So there could be a lot of differentials which could be there. The airway is not being managed properly. There's some reaction to some particular drug. Rigidity because of the chest wall because of fentanyl can present like that, inability to ventilate, difficult mass ventilation. So lots of things which could have occurred at this scenario. Next, please. But remember, next, please. Yeah. But remember, you have to think of anaphylaxis in this scenario. It is a potential life-threatening allergic reaction usually caused by a trigger, and usually these triggers are antibiotics. Remember, we had done a test dose which was negative. Non-depolarizing muscular blocking agents. We had used rocuronium in this particular case. Disinfectants. Now, for this particular patient, betadine and spirit were used for painting the abdomen. Now, since it was not deemed to be difficult, we had told the surgeons to go ahead with painting and draping till the tube was put in to save some time. Latex. Latex energy usually presents in the perioperative period rather than when the abdomen and the tissues are exposed to the powder of the gloves and the gloves themselves, and dyes, which were not used in this particular case. Now, evaluation under anesthesia may be difficult because a median of 8 drugs is used when anesthesia is administered. Now, if we count in this particular case, we had used midazolam, we had used fentanyl, we had used an antibiotic, we had used perinorm and rentoc in the pre-medication. So that is 2 more drugs. Then we had used rocuronium and sevoflurane. So that is around 7 drugs that we had used in this particular patient. So you can remember, and remember even the excipients in seemingly innocuous substances like RL or Na, 7 crystalloids or colloids can cause a reaction. And the unfortunate part, although, is that cause remains unidentified in 30 to 50% of the cases. Now, we cannot pinpoint, right, like in our case, which of the agents could have caused this particular anaphylaxis. The incidence is around 1 in 300 to 1 in 20,000. It varies. NAP6 says it is 1 in 10,000 in UK and France. It is much less in pediatric population and more common in females with a preponderance of 3:1. And the mortality rate as compared to other causes is much more, as much as 9 to 10% as compared to other causes of mortality. Next, please. So, coming to the pathophysiology, 60% of all anaphylaxis are IgE mediated, whereas 40% there's a non-identified allergen or a non-IgE mechanism, which could include direct muscle mediator release, kinin system modulation, non-specific complement activation, or drug-bound IgG interaction with FZGR expressing neutrophils, macrophages, or platelets. So basically, the drugs, they might trigger the IgE reaction, or it might be IgG mediated, which might present in the later stage. Next, please. So the other causes are MAS related G protein coupled receptor X2, that is MRG PRX2, which is a receptor found on mast cells, which is occupied by opioids. NMBA. So remember, opioids can also cause anaphylaxis. Vancomycin, amoxicillin clavulanic acid, anticoplanin, which results in activation and degeneration of the mast. We can also have IG mediated and non-IG mediated mechanisms, which have similar pathophysiology and but activation in serum cells, and which cannot be reliably distinguished with clinical methods. That means you cannot distinguish clinically whether it is because of IgE mediated or non-IgE mediated mechanism. Next, please. So if you see here, this is the Ig mediated allergic mechanism in which the allergen on the it binds with the mature B cells to produce specific Ig antibodies to that particular allergen, and Ig antibodies bind to mast cells with basophil receptors, and this initial phase of sensitization is clinically silent. So on re-exposure, the allergen cross-links two specific Ig receptors, creating a bridge and resulting in mast cell degranulation, which causes the specific reaction. In non-allergic mechanisms, that is, there is a muscle activation because of non-specific activation, histamine-releasing agents, usually mild or moderate immediate hypersensitivity. Then you have calcium and phospholipase C and A2 dependent mechanisms, which are seen in vancomycin and teicoplanin. Then MRG-CPR-X2 activation, which is seen in NMBA. Now, again, this needs to be proven in humans, but remember, it is the NMBAs which has the highest incidence of allergic anaphylaxis in amongst the anesthesia drugs per se, and mastocytosis. So we have COX-1 inhibition, as is seen with NSAIDs, bronchospasms, and duodenum or both. And then there are certain cofactors which may predispose to this particular condition, such as stress, infection, the dose of allergen, the rate of drug injection, chemical property and molecular weight of drugs, and certain host factors. Next. So the clinical presentation is usually number 1, cutaneous, respiratory, cardiovascular. The early signs include cutaneous manifestations such as a rash, pruritus, the respiratory is dyspnea, neurovascular is lightheadedness, cardiovascular is hypertension and tachycardia. Now, if you see that cutaneous manifestations, how many of us seen a small wheal and flare reaction with the administration of morphine or fentanyl? Pruritus. Patient usually itches his or her nose when you administer fentanyl. Dyspnea. Now that may be masked because you have already given the relaxant or the patient is under the influence of anesthesia. Lightheadedness, you have given a sedative, patient usually complains of lightheadedness. And hypertension and tachycardia, you usually attribute it to the higher dose of induction agent or to relative hypovolemia that you see during induction. So remember, all these early manifestations are masked under anesthesia and drapes to some extent. So you have to be very careful to pick up an anaphylaxis in under anesthesia. Next, please. So when we come to the clinical presentation, the most common is the isolated severe symptoms, which is hypertension or tachycardia in 56% of the patients, which is very common under anesthesia. Isolated respiratory symptoms, 18%. Also commonly seen when there's light pain of anesthesia, there's obstructed airway, and also the cutaneous manifestations are also as high as your CVS manifestations, which are 56%, which unfortunately are hidden under the drapes and not visible to the anesthesiologist. And cutaneous manifestations are not usually a presenting feature, and it is variable in different populations, and it is more prevalent in non-severe or non-IG mediated reactions rather than IG mediated reactions. Next, please. So, what are the problems that lead us unawares during anesthesia? Surgical draping, as I said, the cutaneous manifestations won't be visible. There's decreased effective circulating volume masquerading as hypertension and tachycardia. Cardiovascular collapse, again, we think because of the anesthetic agents. There's compensatory vasoconstriction, hypertension, tachycardia, bronchospasm, and desaturation. Again, is may be present during induction or airway obstruction, circuit malfunction, and there are many other causes. But we have to consider anaphylaxis if these findings are unexpected or unresponsive to the typical maneuvers or typical therapy that we usually institute at this particular time. Next, please. So, how do we rate the severity of anaphylaxis? So, there's a ring and Mesmer scale in which this is basically not for patient under anesthesia, but in general. So, grade 1 is isolated cutaneous signs, grade 2 is non-severe multi-system involvement, usually because of non-IG mediated mechanisms. Grade 3 is life-threatening multi-system involvement, and grade 4 is cardiopulmonary arrest or collapse or arrest, which is usually due to IG mediated mechanisms, and early recognition and management is an absolute must in this particular case. Next, please. So now there's this again scoring system which has been used for the perioperative anaphylaxis. So each we see the cardiovascular system and then we see these points and then we give them points. So in the cardiovascular system, we have hypertension, severe hypertension, cardiac arrest, tachycardia, a poor or unsustained response of hypertension to standard doses of sympathomimetics. That can also mean that you have an anaphylactic reaction. A point of care echocardiogram showing a hyperdynamic and poorly filled heart. That is circulatory arrest, basically. That means that there's pooling of the fluid in the vessels, recurrence or worsening of hypertension, then excessive dose of anesthetic drugs if you have given, that is a -2. Surgical induced hypovolemia, acute illness predisposing to hypertension in critically ill patients, medication affecting cardiovascular response during anesthesia, neuraxial regional anesthesia, epidural or spinal, and onset of hypertension after development of increased peak in airway pressure during mechanical ventilation of the drug. So if these are present, the green are negative points, the pink are the positive points, and we total the number of points that are available. Next, please. So similarly, we have the scoring for the respiratory and the dermal or mucosal surfaces. Remember, the pink are positive points, the green are the negative points. So these are not in favor of anaphylaxis. Next, please. And then we have the combination of the number of factors present. So if CVS has 2 more than 2 and RS more than 2, CVS more than 2 and the dermatological more than 2, then based on the timing also, when did it actually occur? So within 5 minutes of possible IV trigger, within 15 minutes, within 60 minutes, and after more than 60 minutes. If it has been after more than 60 minutes, it is more or less unlikely to be an anaphylactic. And so intraoperative reaction is certain if the total score is more than 21, very likely if it is 15 to 21, likely to be an reaction if it is 11 to 14, and possible 8 to 10. And if it is less than 8, then it is unlikely to be an intraoperative hyper reaction. Next, please. Differential diagnosis for hypotension and tachycardia. As I've said, we have anesthesia induction, perioperative antihypertensives or TCAs, sepsis, hemorrhage or volume depletion, MI, arrhythmias, pulmonary embolism, systemic mastocytosis. So all these factors you have to rule out: bronchospasm, asthma, recent viral infection, obesity, mucus plugging, aspiration or a difficult airway or intubation, urticaria and angioedema can be seen with ACE inhibitor use, C1 esterase inhibitor deficiency, or cold-induced urticaria, because temperature drops as soon as we induce anesthesia in these patients. So these are the differential diagnoses you have to keep in mind. Next, please. So coming to the specific agents in MBAs, as I said, they are the most common, and IG and non-IG mechanisms both are implicated. These are substituted tertiary and quaternary ammonium ion structures which bind to IG, and it is similar to ammonium compounds in cosmetics, disinfectants, and over-the-counter drugs with a female preponderance. So since cosmetics are more commonly used by females, so that is why they are more prone to these NMBA related reactions. Next, please. NMBAs, again, as I said, bind to MRGPX2 on mast cells. So this is a non-IgE mediated, most commonly seen with rocuronium, cisatracurium, and mivacurium. Atracurium causes a direct histamine release with subsequent hypertension and bronchospasm. It presents early in the procedure within 5 minutes. And succinylcholine, in fact, has a higher risk of anaphylaxis as compared to rocuronium. And if we rate it, atracurium is more than cisatracurium is more than vecuronium, and least is the pancuronium. So most common is succinylcholine, followed by rocuronium, and then atracurium and cisatracurium. Next, please. As I said, scoline is much more dangerous, and it presents mainly as bronchospasms. And there is a cross sensitivity of 36 to 70% between NMBAs. If there is a negative skin test, then there is a subsequent lower risk of perioperative anaphylaxis. Next, please. Antibiotics. So in US and Spain, it is cefazolin. In UK, it is coimexiclav and teicoplanin. Whenever there was an allergy to teicoplanin, the patients are also allergic to penicillin. So penicillin allergy evaluation is important, as 98% of the labels are incorrect, and it occurs early, 97% within 15 minutes, 74% within 5 minutes. Vancomycin, amoxiclav, fluoroquinolones, and teicoplanin, usually non-IG mediating mechanisms, are present. Next, please. So latex is again one of the most common causes of perioperative anaphylaxis. Incidence, however, is decreasing because of the latex-free policy, powder-free latex gloves, labeling of products containing latex, and it usually presents later in surgery because of cumulative absorption from mucocutaneous and serosal exposure. So that is the most important part. And aerosolized particles may cause bronchospasm. Next, please. Sugamadex. Now the use of Sugamadex is increasing. So in Japanese, there's an incidence of around 30% of anaphylaxis with Sugamadex, but it is rare in the West. It is a cyclodextrin, and it again is common in patients who are allergic to food additives or cosmetics. Again, occurs late in surgery during reversal only. And remember, it is the complex itself can also cause perioperative anaphylaxis. And in spite of the patient not being reactive to rocuronium or Sugamadex per se, the complex itself can be allergic. Next, please. So disinfectant, chlorhexidine up to 10%, onset is around 30 minutes after exposure, and it is faster if impregnated central venous catheters are used. And skin and specific IG testing is highly predictive. Bezitracin and povidone iodine have also been implicated. In fact, we have quite often seen allergic reactions to povidone iodine, not in anaphylaxis, but yes, cutaneous manifestations with slight tachypnea, which responded to immediate scraping off and administration of steroid and inhaled beta 2 agonist. Next, please. Dyes. So blue dyes are used for sentinel node identification during surgery. Patent blue V and isosulfan blue are most common in cross-reactive. Methylene blue, there is a less cross-reactivity, and sensitization occurs because of their use in toothpaste, topical creams, and food dyes and additives. Uh, because their absorption is less, so the presentation is usually delayed. Next, please. The hypnotics, propofol, ketamine, etomidate, and midazolam, although they all can cause allergy or anaphylaxis, they are rarely the culprit. It is the soybean oil, egg, and glycerol and peanut allergy. Earlier, it was said that please do not administer propofol, but now it has been deemed safe to administer in all these patients because the allergy is not to the soybean oil or the glycerol, but mainly to the isopropyl groups in propofol. Next, please. Opioids, it is very rare and uncommon, about 1 in 1 lakh to 2 lakh. Morphine, codeine, and meperidine, they cause histamine release. There is a direct muscle degranulation, and the cutaneous manifestations include urticaria and pruritus, usually not really life-threatening. Next, please. Colloids. So gelatins are most likely. Albumin has lowest risk. IgA and non-IgA mediated mechanisms both have been implicated. There's no known cross sensitivity to different colloids, but gelatins definitely show a cross sensitivity. So you have to be careful with gelatins. Next, please. Blood products. So blood products, there are another commonly used transfusion which can cause anaphylaxis. The rate is 0.6 per 1,000 transfusions. It is higher in patients with IgA deficiency and more so in previously sensitized patients, pregnancy, and patients who have received previous transfusion. Another important mention is protamine. It causes IgE mediated and non-IgE mediated anaphylactic reactions. Prior intravenous protein use or use of protein containing insulin is a definite risk factor for this particular anaphylactic reaction. Next, please. Local anesthetics less than 1%, and esters do not cross-react with amide. So if there has been a reaction with amide, you can still use esters and vice versa. Next, please. So how do we evaluate? The most common and the specific testing is serum tryptase levels. It peaks within 15 minutes up to 120 minutes after onset of reaction with a half-life of 2 hours. So normal tryptase level does not rule out an anaphylactic reaction. So even if the if the tryptase level is normal, it does not rule out an anaphylactic reaction. But persistently elevated levels greater than 11.4 milligram per ml, that means that you have to evaluate the patient for an underlying muscle disorders. Other markers are urinary metabolites and methylhistamine, leukotriene, E4, prostaglandin, D223 dinor B, prostaglandin F2. So that means that if the serum tryptase level is elevated, that means that it is an anaphylactic reaction for sure. But even if the serum tryptase levels are normal, it does not rule out anaphylaxis. It can be non-IgE mediated. Next, please. Skin testing. So skin prick testing followed by intradermic testing is helpful in allergen identification, but there can be false positive results due to irritant reactions. And skin testing to antibiotics other than penicillin is not standardized, unfortunately. So again, the incidence of false positives may be high. Next, please. So this is the normal dose, undiluted dose, which is used for skin testing or intradermal testing, and that is how you should be administering. So we have the agent for NMBA, hypnotics, opioids, dyes, and antiseptics, and NMBA reversal for sucamadex. So these are the dilutions which are you're supposed to use for skin prick testing and intradermal testing. Next, please. So for chlorhexidine, there's a specific IG which is 100% sensitive. Uh, for perioperative anaphylaxis, specific IG testing is limited, as I said, because there are too many drugs that we have used, so you don't know how many drugs you will test for. Latest specific is again 97%, beta lactam antibiotics 85%. For NMDAs, it is specific but not sensitive. And IG testing is an adjunct to skin testing. So what we can do is basophil activation testing. It measures the surface CD63 or CD203 expressed on basophils and evaluates immediate drug hypersensitivity. And there's a 73% to 100% congruency between BAT and skin test for. So if you are suspecting because of NMDAs, you can go in for skin testing and BAT. Management. So based on the ring and Bessemer grade, for grade 1 nothing is needed. Grade 2 20 microgram bolus of epinephrine, and grade 3 50 microgram bolus or 100 microgram bolus if previous suboptimal response to other vasopressors. If suboptimal response, we can further increase to 200 microgram, and dose of epinephrine can be repeated after every 2 minutes. And for grade 4, when there is arrest, we go as per the ACLS guidelines. We give 1 milligram diluted to 10 ml as a push, followed by CPR if required. And we can, if refractory, we can initiate epinephrine infusion at 0.05 to 0.1 microgram per kg per minute. Next, please. So subsequently, what you have to do is an allergy consultation and communication, thorough review of the perioperative record. You have to know that there is no evidence of pre-medication with antihistamines or corticosteroids, which will prevent an anaphylaxis. DNA aptamer binding MRG PRX2 prevents anaphylaxis in a rat model. This is experimental. Key remains in identifying the culprit and avoiding it. And if no culprit is determined, alternative agents guided by negative skin testing are to be used for these particular patients. Next, please. With that, I'll end my talk, and I hope I was clear on the incidents, the etiology, pathophysiology, presentation, and the management of perioperative anaphylaxis and how to avoid it. Thank you very much.
Thank you so much, sir. Thank you for your overwhelming talk that you have shared on our platform and for making our viewers understand about tech on such a special day. So, thank you so much for that. Moving ahead with the question and answers round, so we have received few questions from the participants. So, with all your
Yeah,
due
sure.
permission, I would like to put across the question to
Yeah,
you.
sure. Please.
So, the first question is related to immediate management. So, what is the immediate management protocol for a patient experiencing intraoperative anaphylaxis? If you can please give your point on this.
So the thing is, intraoperative is simple. If you have ascertained that it is an anaphylaxis, push in fluids and give administer epinephrine. So drug of choice for anaphylaxis is epinephrine and nothing. So dosage I've told you, if it is mild 20 microgram, if it is severe 50 microgram, you can go up to 200 microgram bolus. And remember, it's all IV. And if you suspect a circulatory collapse or an arrest, then you go as per ACLS guidelines, 8 minutes of efficacy.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question, and the other question is how should anesthetic agents and other medications be re-administered after an anaphylactic reaction to confirm the cause?
See, the thing is, as I said, you have to identify which caused it. So timing when the reaction happened, but during induction, many drugs are given at the same time. So you have to do a skin testing and specific testing and an interview, and then only you can find out which drug was the culprit, and then in the next instance, avoid those particular drugs. That is the only way forward. Nothing else can be.
Thank you so much, sir. Thank you for answering that question. Like you were talking about skin testing, we have a question related to that. So, in a scenario where a patient develops sudden hypotension, bronchospasm, and skin changes during surgery, what differential diagnosis should be considered?
So I've already mentioned that it can be a simple allergic reaction. Anaphylaxis, as I've said, that there will be a component of respiratory and serious involvement, and it is almost immediate. But then, if as I said, it can be rubbing, vigorous, and there can be many other things. But there is a local histamine release also. There is a wheel and flare reaction also, and that can cause lead to redness and wheel and flare reaction. And you have to rule out other causes, common causes, before declaring it as an anaphylaxis. But if there is a circulatory collapse, or if there is a severe bronchospasm, or if these signs and symptoms are out of the ordinary, then you should certainly suspect anaphylaxis, recognize it early, and treat as soon as possible.
Thank you so much, sir. Thank you for answering that question and all the other questions for our viewers and for making them understand about the topic in such an elaborative manner, in such a simple manner that everyone can understand. So, thank you so much, sir, for your adherence, for your PPT presentation that you have shared, and for making so much of efforts to make our viewers understand about it. With this, I would also like to thank all our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. So thank you to all of them. And before concluding, sir, last take home message from your end.
So, last take home message is identification is key. Please do not delay in identification and anaphylaxis, and treat it properly. And you have to have a proper review of what caused it, and then avoid those particular.
Thank you so much, sir. Thank you. With this, we would like to
Thank
conclude
you.
the talk here for today. Until next time. Thank you, sir.
Right. Thank you. Thank you so much. Thank you.